طيب السلام عليكم ورحمة الله. أسعد الله أوقاتكم يا رب بكل خير. الحمد لله الذي علم بالقلم علم الإنسان ما لم يعلم. Welcome all in our today meeting. You are all welcome in our class today. Is there any question or any concern؟ في أي أحد عنده سؤال أو استفسار؟ طيب. Now, in our last meeting, we already discussed about the wound care main player. So we were now aware about the process in general, how we can first to revise our theoretical framework, how this training already works, and the progress or the way that we lead this training. حكينا إنه إحنا في عندنا theoretical framework. This start by a kind of knowledge, and this knowledge will lead for skill, and then after the skill we will go for the competency, or we will be able to transfer this information to the part of how we will utilize or use this as a skill-based component. Today we will go for the wound assessment, and we will understand more how we can communicate in the nature of languages related to the wound, why this is already important part. Is there a specific way that we can speak with the language? And at the same time, do we use the same terms and descriptions for the wound? For example, if you are talking to me and I wanted to describe for you a wound, are you able to draw a mental image that will explain for you exactly what's going on in this wound? There is an international agreement about methods or guidelines. In this way, we can together work until we are building this mental image about the wound. What are the problems or challenges that in the wound assessment? Each one of us has his own point of view, right? Even, I don't know if you're remembering before 4 years, 3-4 years back, when the issues of the woman dress, either it was blue or green or black, because even we are seeing the same picture, we are differing how we will define it, right? Maybe someone will look more for the proper way of the wound. Others looking for the negative sides of the wound. Others seeing that this wound is getting to be suitable or healable wounds. Others, so we need standardization, and this standardization should be variable. That means what I am writing now as assessment, I am communicating this information with my colleague, or maybe will come tomorrow or the following day. And on the same time, I am communicating with myself. Because after a couple of days, I will come to say, is my decision was a proper way for treating the wounds or not? Is this wound going for healing or deteriorating? So we need to know how I will reflect this in the actual word of the wound care. So this is the components. This is how we will be able to catch the etiology of the development of the wound, the appearance and the characteristic. And in today's presentation, we will talk in general about it, because there will be some additives that will come when we come for specifications in the pressure injury, specifications for the epileptic foot, specifications for foot injuries, either vascular or arterial or burn or etc. But here we will talk more about it. The second issue in the wound assessment, that we are not looking for a hole in the patient, rather than we are evaluating the patient as a whole. This is famous expression in the world of the wound care, that we are not going to say that we are only focusing on this open in the skin of the patient, rather than we are evaluating the overall patient condition, because there are a lot of factors that lead for this wound to happen and keep progressing the occurrence of the wound. that not related to the wound that you are seeing, rather than there are other factors inside the patient. So this is the challenge that we have. We need this way of communication. So I should be able to speak with you or anyone working in the wound care able to understand each other. That's why the term of the wound care language starts to appear. And I will be in need to communicate with myself, but in different time. When the patient come back, I should not rely on my memory to understand how was the wound at that time and how is the wound now, and then is the wound going to progress or not. And also I will be able to catch all the problems that patients suffering from. So this is the way that we are looking for. This methodologies for the wound assessment, it's not only for special team focus. So the wound care or the people working in the wound care or people working with the wounds care could be physicians, nurses, therapists, other kind of healthcare professions. On the same time, there are some technique and tips that if we able to communicate it with the patient's caregiver or the patient himself, so this will help us a lot to draw back how the progress of the wounds happening, and we will be able to deal with the comorbidities factor or the problems that stop the wound from getting better. So let's here start by entering the patient to the clinic or referring the patient to the wound care, the first point of contact. What I will evaluate or do for this patient as opposed to how I will evaluate the patient. And important issue for us, it's essential and cornerstone in understanding how I will deal with the wound is the concept of healability. And the concept of healability, this is what comes from the wound bed preparation. Look, maybe it looks like strange that any patient come to the clinic of the wound care or refer to wound care specialist. The purpose that the patient looking for is healing the wound. So I want the wound to be closed. But this is not always the case. The healability, this is the concept start to be used and adopted after 2003, which is the wound bed preparation start to appear, which is referring to the way that I should collect information for the patient regarding to his condition and the wound status to be able to classify the wounds over of one classifications or one category among these three. Healable wounds, maintenance or stagnated wounds, in some references they refer it to be in this way, or non-healable wounds. Yani, from the beginning, you will be able to end your goal of treatment. That in the healability, that this wound will be healed. So I will go for a treatment approach. I will build my decision for dressing, for the ways of the product that I will use it, that this wound is healable. So this wound had an end, and this end will be in a closing and epidermal layers to be built over the gap of the wound or the wounded. While there are another category that this is non-healable wounds. There are some factors related to the patient condition that lead these wounds that will not reach for fully healable. But my priority is to stop the deterioration. So my thinking of how I will deal with the wounds, my objectives, dressing selection, procedures should be differ between healable and non-healable. I will give you an example, and this is only for illustration. The sharp debridement, it's a well-known technique in healable condition, but in non-healable wounds, the patient unable to build the new tissues, I never use the sharp debridement. I will go for the other conservative way of debridement. Why? Because what I'm doing now, I'm doing the same what Dracula said. I just make the sharp debridement, remove this by the knife or needle or whatever the techniques that I'm using. And what is the result? The wound's getting bigger, but there is no ability in the patient's body to build the new tissue. So my strategies all differ. And the third category, there are wounds stuck in the middle. It's not healable On the same time, there is a reversible factor that if this factor fixed, the patient will go for healable status for this wound. If this factor or this antecedent aspect, something happened within the patient body, did not solve, the patient will stay in non-healability. For example, patient in the diabetic foot and had a vascular problem. But this vascular problem can be solved and the vascular surgeon working on it. So the patient wound in this case in maintenance status. Of course, my strategies will differ. This is important to end up in our assessment that I will evaluate the patient condition either in the healability, so I will go for a treatment plan, either for non-healability, so I will go for a treatment plan but differ from the first one, or in the maintenance, so we will work to support the patient to push him toward the healability condition. Now, let's start by the physical examination. I just will pass through it quickly. It's not a concern for this diploma, but this is important skill for the nurses, doctor, pharmacists, anyone work in the wound care about the physical examination. And it's apart from well-known accepted techniques that adopted by almost all healthcare professions, physiotherapists, nutrition, and so on. One of the famous techniques, they call it Heidi. It's not the same Heidi that was animation in our time. Rather than here, it's an abbreviation. We will take the history of the patient, the illnesses, medical, surgical history, any problems, any issues associated to trauma for reading the wounds, and so on. Examination, of course, and this is what we will focus. Investigation, basic investigation and related investigation. There are some baseline investigation about the patient's hemodynamic conditions, and there are related investigation, like if the patient with the diabetes, so we will go for hemoglobin A1C and fasted blood sugar. If the patient had an infection, so we'll ask about CRB and so on, white blood cells and so on. And we will define a diagnosis for the wound either based on the categories that we'll pass through. This wound is a pressure ulcer? Is this wound is diabetic foot? Is it make a difference? Yes. What are the kind of this difference? This is what we will discuss after finishing the basic modules. But for example, the type of bacteria will differ between pressure injury and diabetic foot and vascular ulcer. The kind of moisture that will come, the pain of the patient. So my strategies in treatment will be in a part differs based on the definition of the wound or diagnosis of the wound. And this all will lead for a plan of care. So we will end up to say, okay, this patient, we will use this strategy in the wound dressing and wound procedures and so on and so on. Now we will go for evaluating the wound. This is the hot topic. This is the things that we are looking for to know about it. Part one, technical points in hospitals, and it's a debatable issue. There are a lot of discussions about it. في نقاش كبير وعدم اتفاق حول هذه النقطة. Do we need a special wound care format or not? The people now who are working on the paper-based hospitals or healthcare organizations, some of these hospitals or institutions had a special form. They call it wound care assessment form, something like that. Other hospitals, they are not referring to the wound assessment or a special format. Paper that they write, and the same issue happening for the electronic medical records. So the people working on Cerner or Hakim or Sihhati or Ashifa, we have now more than hundreds of electronic medical records. That do we need a special window for the wound care? This is a debatable issue, and it's referred to the status of the hospital and the policy there. So this is not our priorities to go and define it, but regardless of both, we will discuss what should be written there. What are the aspects that we should end this information towards? There are people saying that there is no consistency, so we are looking for consistency. Others, they say, we assume the people who are working in the wound competent enough, and we are able to build this consistency. So the studies and the reference said, regardless if there is a special form or not, there are specific important components should be available in these forms. So either we have this form or not, these components should be filled and getting on. The first ways of this debates ending by this way. Experts said if the documentation of the people working in the wound care satisfy the elements of the wound assessment, so we are not in need for any form. But in this case, they call it unstructured documentation, and this will be relying more on narrative way of description, and it will be just a qualitative text. Other, they said no, we need specified number. Yani they want to transfer these elements to be a quantitative, so I will end my documentation to say that the wound status in this condition is 12 or 10, and we will see if patient go from 12 to 10, that means the patient either deterioration or improved, depends on the methodologies that we use. So last time we start to talk about the wound assessment or elements. Anyway, both should have this wound assessment or the main elements. In the last time, we start today to talk about the main component of 3 by 3. 3 by 3, that means there are 3 aspects. Under each aspect, there are 3. So we will end by 9 points to formulate the wound assessment and the wound care in this way. Before we go for this one, the documentation is very important for the quality of life, about able to coordinate our management of care. This is apart from the international guideline of the pressure injury. And they said that based on the assessment, we will be able to determine the goal, and if there is goal, then there is treatment. So based on that, they say that there should be an assessment and at least gap for comprehensive assessment, and this gap will be 14 days. And they discover that within the 14 days, there are 2 benefits. We will be able to evaluate the efficiency of our objectives. So we will end to say that, yes, this objective works, what should we work, and give a proper time for the dressing or treatment plan to achieve this one. So 14 days or 2 weeks, which refer to this one. This is important that when you go for a plan, of course, on daily basis, you have a quick ways of evaluation, but after finishing these 2 weeks, you have comprehensive assessment that should cover all the components of 3 by 3. The evidence is about it is accumulated, so we are talking about more than one piece of evidence. It started from the experts in the pressure ulcer. Now it's already accepted among all the people working in the wound care about the 2 weeks gap in evaluating the wound. And of course, there are a lot of accumulation evidence from the expert opinion, and that some say that we should take the patient condition. In some cases, we need to do it in more frequency, but at least we are able to evaluate our objectives of treatment within 2 weeks. So let's start here by the structured format, which is that 3 by 3. So we will know that the peri-wound area, wound edge, and wound bed. So we have a component, 3 components under the peri-wound area. So this is 1, 2, 3. Under each one, there are 3 components, 3 components, 3 components. So we will end up by 3 by 3, the figures. Last time we start to give an introduction about the peri-wound area. What is the peri-wound area? Peri-wound area, from its name, it's before the wound. So it's the piece of skin that started from the wound edge until the color of the skin came back to be normal. Before, my first experience in the wound assessment and wound care, they were teaching us about 4 to 5 centimeters. So if this is the wound, so they said, okay, go 4 to 5 centimeters, and then this is the peri-wound area. So you put the line, and you said, okay, this is 4 to 5 centimeters. Maybe here the circle should be bigger, and this is the peri-wound area. But they discovered that in some cases, the kind of skin can extend for more than 5 centimeters for some reasons. Then they start to analyze the condition of the epidermis tissues, and they say that when we have the normal skin to come back to its previous color, or the skin or the body color, that means we are in the proper way of dealing with it. So we will go to evaluate this condition. So if I have a wound, let's say this is wound, and the peri-wound area will be all the space until the color of the skin come back to be the same color of the body. In this case, this is the way that we will describe or put the boundaries for the peri-wound area. What are the things that I should see within the peri-wound area? Number one is the color of the skin. There are two categories. We will end up the color of the skin on it. First one, this color is a fresh tissue. It's more shiny, whiter, and that means the wound is getting better. There is healing progressing happening. Why? Because if the wound will get to be smaller, it will come from the edge. So it's an edge-based healing. If the wounds will getting to be in a bigger, so it will start from the peri-wound area. So the wound bed will start to elaborate and take the peri-wound area. The other category, which will be the darker. So if the peri-wound area was darker than the normal body skin, it's more related to say that the wound is getting worse. The wound is going deterioration phase. Okay, so this is the first one. The second one is the adhesive related trauma. Even with the current advancement happening in the wound dressing, but there are still the plaster that we are using in the wounds. When you're putting the wounds and removing the wounds, putting the wounds, removing the wounds, it can lead to detachment of the epidermal tissue in the peri-wound area. Because this is, for example, this is wound. You will have a dressing to cover it in this way. Let's say, for example, 2 inch by 2 inch. So it will cover all this area. There will be an exposure for the acrylic ways of the dressings. البلاستر تلزيق نفسه على الجرح, and it will lead for adhesive related trauma. So in this way, we will say if it's present or not. If it's present, how I will describe it. Here, important point to consider when we are talking about the patient's wounds, that we will use our location based on the clock. What is the location based on the clock? We will say that we will refer to the head of the patient as we are looking for a clock, for your watch or clock, that 12 refer to the head of the patient. And 6 refer to the toe of the patient. Okay, remember that we're talking about the toe, not the foot, so we'll not get confused in the diabetic foot. And there will be here a 3 and here 9. And now, if I see adhesive related trauma in this way, in this location, I will describe it in the following way. Adhesive related trauma present at 10 o'clock or at 10. So the one who will read your note will understand that there is adhesive related trauma in this location. Maybe I noticed that adhesive related trauma at 4. So they will write in the peri-wound area the color of the skin, and there is adhesive related trauma at 4 o'clock. And so in this way, we will be able to know exactly the location and how's the location. Because this one will be described in the depth and how many, the condition, how many centimeters and so on. The third one is the exudate and the fluid management. And this is important because it's referring to the wound care or quality of the wound care. The wound itself can have an exudate. This is something can happen from the status of the inflammation, as we said before. But this fluid, if it's come to the peri-wound area, the peri-wound area is not place for producing exudate. Wound itself produces exudate, not the peri-wound area. So what that means, there is low quality of wound care. لأنه either the exudate had not been managed well, so it's come to be sucked and go to the peri-wound area. طيب, okay, so what's the problem? It's from the body to the body. منكم وإليكم. شو المشكلة يعني لو صار في شوية exudate و fluid accumulation في peri-wound area? There are consequences for this fluids happen. First one, it will burn the peri-wound. لأنه different temperature. الحرارة في سطح الجرح 37 the temperature of the body. But the skin 33, 34. So there is difference. So this is the first one. Second, the wound exudate full of enzymes that can negatively affect the peri-wound, the skin and the keratinocytes in the peri-wound. So it will lead to be detached. Number three, it will lead for maceration. Mostly will be seen in the wound edge, but also can be noticed in the peri-wound area. And that means the wound is expanding if there is exudate and fluid accumulation in the peri-wound area. Because here the status of the wounds, we are talking about peri-wound area, still it's a skin with the keratinocytes. When it's have the exudate come from the wound to this status, it will lead for deterioration for these tissues. So it will lead for a problem. So these are the three components. So peri-wound area, we're talking about three: color, adhesive, and exudate, or they call it CAE. So for you to remember, color, adhesive related trauma, and exudate. The second component we have it is the wound edge. What is the wound edge? It's the point that splits the peri-wound area on the wound bed. The barrier between, or the points that the peri-wound area end and the wound start. And this edge by its name, حافة بالعربية, we will looking for the maceration. What is maceration? Maceration, it's a condition. Now, this is the cell of keratinocytes. Let's here choose one. Here the keratinocytes. And for the keratinocytes, when they start to maturate, when start to build centroles here and centroles here, and then you know the deviation process, we will have the mitosis in this way. I'm sure that it's apart from the biology 101 class, and then the mitosis here, they will start to take the genetic material and it will end by two cells, right? So this is the mechanism, simple mechanism for cell division. Okay. Now with maceration, which means accumulation of the fluids, because of the osmolarity, these cells start to be enforced to contain a lot of fluids that more than the cell's ability to accommodate. So it will lead for bigger size. Okay, so it's fine, bigger size. The problem that this big cells and functioning cells, because stretched in the cellular membrane, and at the same time unable to divide. Because when the centroles go in this direction, cannot reach to the end of the cell wall to start the division. But it should go for division, so these cells will lead to death. So the maceration, it's a very bad consequence. When the cell getting a lot of solutions, more than its ability, it will get enlarged and it will be unfunctioning cells. In the keratinocytes, in many cases, if you are unable to solve the maceration issue, you should debride it, you should remove it. because this keratinocytes will not allow for a fresh keratinocytes or new cells to come to cover the wound, and at the same time it will be a barrier that unable to deviate or unable to produce any tissues and will not allow for any healthy tissues to come. So this is the maceration. I will give you, it's similar, it's not exactly for you to get to the maceration. When you go to the swimming pool or to the sea and keep playing in the water for a couple of hours, then you will feel your fingertips, how it's getting to be macerated or fragile in the ways of killers. So this is an example that will give you here how it will become in this way. ولا تسأل فشفشة. Exactly. يعني ممكن تزبط معنا مصطلح فشفشة. Yes, thank you. So this is how it's become in this way. In this part, if you are in the swimming pool or رحت على البحر الميت or in any sea, you will feel how it takes time the wounds to heal until this maceration to be disappeared. The other points that we should check on in the wound edge is the tunnel. What is the tunnel? Within the wound, this is the wound edge, you will feel like a cave going inside. In one direction, it's deep under the peri-wound area. So it's connected to the wound bed under the peri-wound area. And it will be in one connection. Now, this should be closed, so you will be able to determine its end, even if it's pocket inside, but still closed. If it's open to another organ, this is a stoma, and this is not an wound care function. We should refer it direct, the patient to general surgeon, to work to close this stoma, because this leads to another organ, so it will be massive. But in the tunneling that we are referring to, it's closed. Okay? But it's one cave in one direction. Again, here in the maceration, when I come to describe it, it's not necessarily to be in all over the wound edge. Maybe it will be started from 12 to 3. So I will write from 12 to 3, there is maceration. This is, or maybe from 12 to 12, so all over the wound edge. The same for the tunnel. I should first here determine its location. So in this example, it's on 7 p.m., 7 o'clock. So we know exactly this is the location of the wound edge condition. The third component is the undermining, or in some textbook they call it epaulip of it. So what is the epaulip? It's similar to the tunnel, but it's shallow and take more space. So you will see the skin flaring. بتشوف السكين برفرف حوالين الجرح. Under this skin there is no tissues. And this is part from the wound edge. So this is the undermining or epaulip. So in the wound edge, we have 3 components. What are these components? Maceration, tunneling, and undermining or anterior. Okay. So maceration, tunnel, undermining. I should evaluate and assess the wound's height. We will go for the third component, which is the wound bed. In the wound bed, we should determine the size of it. In the same way, I will start from 12 to 6, from 3 to 9. So in the assessment, we will write it in this way. From 12 to 6 here, 2 centimeters. And from 3 to 9, 7 centimeters. So we know exactly the diameters of the wound. And we will determine the depth of the wound. Before they were taking that, take more than 1 point and make the average and so on. But now the new guideline take the deepest point as the depth. So you will end assessment by the depth, for example, 2 centimeters. And you will write it in the following way: 2 multiplied by 7 multiply by 2, as we'll see now in the examples a little bit. So directly, if anyone specializes in the wound care and following the international guideline, they will know this 2 refer to what? 12 to 6. This 7 refer to what? 3 to 6, 3 to 9. And this 2 refer to the deepest point. Now, deepest point may be here, maybe here, maybe here, maybe. But take the deepest point. This important to determine the size in the 3x3 methodology. And we will go for the tissue type. In the tissue type, what are the color you see on the assessment? Don't give judgment on this level. On this level, you just describe what you're seeing. There are 2 points you should consider in the tissue type. First one, what are the color you are seeing? And the distribution of this color. So I'm seeing from 12 to 3, black tissue. From 3 to 9, yellowish tissue. From 6 to 9, I'm seeing granulation or red tissues. From 9 to 12, white tissues. So I'm describing where are the distribution of the tissues that I see. Now, it's not necessarily to be from 12 to 3, maybe from 12 to 4, maybe from 12 to 8. And the percentage of this distribution. So try to estimate it from 100%. These 4 components, for example, I can write it from 12 to 4. I'm saying black and 20% tissues. So in this case, I am referring to the type of the tissue and the distribution of these tissues over the wound. So in the wound bed, I should evaluate the size, the type, and distribution. In the type, on this level, please don't give judgment. Why don't give judgment? Because there will be some confusion. We all able to differentiate between necrotic black tissue and red granulation. But the confusion can happen in the following way. As how do you know it's red color? This is granulation, not biofilm, as we will come later. Because they are similar in the color. And it needs more than simple techniques to give this judgment. The same for the white color. White color can be referred to tendon or bone or dead muscle tissues or slough in the last phases. So this is all important to detect, and just be careful when you give this this judgment about what you are evaluating the wounds for. This is a screenshot from the guideline, the international guideline, and it directly refers that some additional points you should take it during this assessment. First is the anatomical location, so we'll be able to describe it based on the anatomical location, and for the pressure injury, to add the category and stage, and also to describe the exudate and odor, and this is expert opinion, and not agreement about it in all conditions. So it's fine. So this is the ways to write my notes. I can write it on any piece of paper. I can write it in a qualitative way. Wallahi, if all the team and the people working in the wound care agree on this principle, so it's fine, good, go, do it. It's just wording options. Can give some space for the people to express themselves in writing and provide the information, especially when you are the same one who's following, or you will follow the same patient over extended period of time. So it will be very good that in the home health care, for example, or for clinic, so the patient come to your clinic, so you will be able to express it for yourself and take this basic information. But this is not always the case. There are a lot of debates. First, start on the research based. For example, wallahi, I have 2 kinds of dressing, and I want to end my decision on the policy base to say that this dressing better than this dressing. So you write here words, this is qualitative, and you write here words. How I will judge which one is better. Another point started from the insurance company, which say that how I will evaluate the quality of care in this hospital, or for this doctor, or for this nurse. Are the patients getting progress or deteriorated? Am I paying the money in the proper way or not? The International National Pressure Ulcer Advisory Panel, NPUP, they suggest a specific tool, simple, direct, and satisfy these objectives. To say that I can give you a tool that able to give you quantitative result for the wound status. So good. Wallahi, what's the name? قالوا اسمه pressure ulcer scale of or push. And this is what we will discuss and take. And the Canadian part, they said, we have a spinal cord inward pressure ulcer monitoring tool. This is less to be used comparing to the pressure. So I will just take this as an example of this one for the pressure ulcer. What is the push pressure ulcer scale of healing? Developed by National Pressure Ulcer Advisory Panel as quick, and this is from their own website, quick, reliable, so who's ever use it. If I use it or any one of you use it, our results should be closely related or near. So the reliability on the research base is good. And it's give a good result in the research, in the wound assessment in the hospitals, and also for the insurance company to know the quality of care, the progresses of the patient, and so on. And it's done on it a lot of tests. We have the principal component analysis or factor, exploratory factor analysis and confirmatory factor analysis. Inshallah, if you continue in the master and the PhD in this one, you will explore it, how we will end up by these three components as it will come. And it's give with a frequent result. This is also from the International Pressure Ulcer Guideline, the international guideline, and they say they mention the benefits, a lot of studies already used, and the reliability of this. So what is this tool? It's already free, available, used on the internet, and freely to be used in any hospital, in any academic. The only one condition, they put it on the commercial and the product or the company-based research. But for anyone, already free to use. They said, we will predict the pressure ulcer scale of healing progress by predictive tool. We will make a calculation by centimeter and multiply the length by the width. So this is the first factor. And we will evaluate the exudate amount, and then we will reflect it on number. And we will evaluate the exudate amount and reflect predominance or the most expanding type of tissues. الأنسجة الأكثر, the most seen tissues in it. And we will end it in this way. So this is that we will explain it, which is the tool 3.0. This is the last copy. We will end by making the number or a numeric factor for the wound in this way. Length by width, so we will not take the depth, only the length and width, exudate amount and tissue type. Wallahi, you will make a calculation. You will measure the length of the wound and the width of the wound. For the pressure ulcer, this is the tool already originated or designed for pressure ulcer. Now, if the score of multiplication here was less than 0.3 centimeter, so the score here will be 1. Wallahi, this wound was 4 centimeter by 4 centimeter. Okay, 4 by 4, how much? 16. We'll go, where is the 16 come under which number? Under this number. So you will take this number. So you will write here 9. So clear? If it's, for example, 5 centimeter by 5 centimeter, so it will be 25 more than 24. So you will write here 10. So you will take the number here, this number that you will take, and this is the number of your multiplication. And for the exudate amount, you will evaluate the status of the wound on 4 categories: either no exudate, light exudate, moderate exudate, or heavy exudate. And they describe that heavy exudate, this need dressing to be changed in the normal polyurethane foam, normal polyurethane, not جيب لي super absorbent وتقول لي والله daily basis. Normal, to be more than one time per day. Here on daily basis, here on every other day, and here there is no seen exudates, even with the dressing change. And you will end here a category. Either you write 0, 1, 2, 3. And the tissue type, if the predominance, the most seen type of tissues, الأنسجة اللي هي أكثر, يعني not necessarily to be all, but الأكثر, more than 50-60% of the tissue. If it's epithelial tissue, so you take 1, granulation you will put 2, slough tissue you put 3, necrotic you put 4, and you make the calculation. That's it. This is in a simple way of making the bush. On the same format, so this is how you will take, but you will measure from 12, as you said, and from side to side, and the score will be in cubic centimeter, بسنتيمتر المربع. يعني خلينا نطلع على هذا الجرح. We will see these wounds. This is the 12, and this is 6. It's 7 centimeter, and from side 3 to 9. This is here 3 to 9. This is 4 centimeters, so 7 by 4, 24 centimeters. So I will go here to the guideline, 24. So this I will write 10 on this status, right? طيب, I will go now to see the exudates. Wallahi, in the last time of the exudates, there is moderate amount of exudates. So I will write 2 in the exudates and 10 for the side. And what do you see here? The most tight or predominant tissues tied. You will see this is slough. I hope the photo is already clear for you. So I will write 3. And I will take the calculation. I will take the summation. So the sum of this is 50. So this is the push score for this patient. This is regarding to the push. I will end it. That's it. Now, if I will use the 3 by 3, this is the very wound area. This is the wound edge. I will check for the tunnel here. I will check for type of the tissue, the depth point, and so on. But here, to know the difference between both. This explanation for the exudate amount. This is explanations for the tissue type. In the same tool, they end by this chart. And this chart now at least should be evaluated for the patient every 14 days, as we said, every 2 weeks. But of course, it can be done at any time, but you should write it here on this graph. The maximum number that will be reached for any patient, 7, and 0 means there is no wound. Now, wallahi, if in each day, for example, I will write today some 14 July, tomorrow 15 July. Now, as we said in the guideline, should be like 2 weeks, 2 weeks, 2 weeks, and so on. And I will see if the scale and the scatter that going down, if the line going down, oh, wallahi, we are fine, the wound is healed. If the line going straight, there is no any improvement. If the line going up, there is deterioration. So in this case, regardless of who was the wound care specialist, or the patient was in the same hospital or not, or the same institute or not, we will be able to give a decision. And this can also give us the faster prediction for healing. So if I go from the 17 to 10 or 9 in fewer number of days, I can estimate how many days still I need if I keep the plan of care to be going down. That means my dressing or my treatment plan is better, the patient getting, alhamdulillah, and getting improved and so on. Ethically wise, special consideration for this tool, that for any hospital that will use it, they should send an email for this email to inform them that something, this blah, blah, blah happening. And this is what we did. I was working before under the umbrella of Ministry of Health in Saudi, and we sent this and they already approved it. So if you are working in Ministry of Health Saudi Arabia, it's already approved. This is what I know. There are, as we said, there is copyright restrictions. So if you're going, for example, to be applied in Hakim, in the electronic medical records, this need to be approved before uploaded on the system, and it's already free available. They had some restriction only for the commercial use for the companies, and there are a lot of evidence about it. The staff education is already approved. This is the way how we will fill the form. I will give you an implication. This is from my experience. I did this research, and I will tell you the issue or the problem that for this research. We have problem regarding to the mechanical hospital. يعني الشركة باعت للمستشفى 2 type of dressings. From my perspectives, they are almost the same. The only difference is that this built by a United States company and the other, I think, a German company. but they are doing the same job. It's not similar in the shape, in the way, but from the pragmatism point of view, they are doing the same. And I was asked that, okay, Abdul Karim, yalla, we are in the budget cut and we wanted to reduce the cost, so please look for these products, what we can cut. I told them, oh, both are doing the same. They informed me, okay, which one is less efficient? And this is really a challenging question at that time. So we said, okay, let's do a research, and then we will investigate this idea of the research. So we take 32 patients, and here the question or the problem. I cannot wait until the wound healed. Maybe, in the hospital, the patient can come and go and discharge, coming again. So based on what we can conclude the decision. So we used the pressure ulcer scale. We come to say, wallahi, we will measure the pressure ulcer scale of healing before the dressing for a group of 16 patients. And for 16 patients, and we will take the mean. And we will measure the pressure ulcer scale of healing after 14 days. And we will measure for the same number of patients the pressure ulcer on weekly base. So we'll measure it again after 21 days, and here 16 days, and this is day 0. Among these two groups, and we define that the delta push. What is the delta push? How much the difference will be? Both dressings are good. They are both coming from international companies, a lot of researchers, a lot of. So based on what we say, if the mean of differences in the push getting more, that means the healing getting healed faster. So we will be able to define, and this is the results that we end up. One type, the generic name or the scientific name called monofilament dressing, and the other one is integrated. And we take it based on the changes happened in the pressure ulcer score of healing number 3, and we conclude that the monofilament lead for this number of lowerment, while the integrated lead for this number. So the number or change in the push happening in the integrated dressing was better. So we aim to conclude this is the way of using dressing. Later, another study that we conduct, based on our experience in the previous study, about a problem related to use of collagen and self-adaptive dressing. We will come to these products later. But we have two techniques. Usually, we use it at the end stage of the wound status. Either we will put collagen, or because we still having a lot of exudate, we will use the kind of dressing we call it self-adaptive dressing, and there are a lot of types now in the risk. Some of my team at that time, they use both. They use the collagen and self-adaptive dressing. And in fact, I don't have any clinical evidence or scientific evidence if I can use both or not. But the nurses assume that if I use it both, the result will be better, because in this case, I give collagen and I control the exudate much better. So we said, okay, let's do research. Already we have the data, so let's do the research. Anyway, we end by using both. The dressing is not significantly lowering or fastening the healing, and it's just only additional cost on the patient, so it's better to be removed. But here I'm able to differentiate the progress of the patient condition based on the mean difference of the patient. And this is just only an example how I will deal with this condition. However, this is a good option. Here I give you some examples here, so please try to practice yourself about how we will do the measurement scale or the push scores. This is the main wound, and this is all adhesive-related trauma. And I am here meaning to say that there are some problems in the push score that they will focus only on the main wounds. But what about the peri-wound area, right? So this is another example. Here we can see about the deep wound. It's maybe 4 centimeters by 2 centimeters, but there are depth 2 centimeters in the push score did not take it. The scientists, they say, the push score is good, but it's not excellent. Still, even if I am using the push score, I still need to write. So what is the benefit? I should, in this case, do two forms. I should do push and still keep writing. So they make a lot of debates. The other issue that international groups, they say that we guarantee the benefits of push for pressure ulcer, but use it for diabetic foot did not give the same let's say, reliability. And there are some specificity and sensitivity. ليه؟ لأنه والله in the fact, يعني we are all working in hospital. Do you think والله the nurse will bring meter and keep measuring in front of the patient family and the doctors and wearing the gloves and removing the gloves? يعني some practicality issue, right? يعني when we are sitting والله today at home drinking the tea under the AC or fan, and we are discussing, right? Theoretical. But when you go to the ICU with the pumps there and mechanical ventilator and doctors, and you just stand and waiting the assigned nurse to come and give you the excuse or support. So there are a lot of, and this is not only in our condition, this is international feature of any hospital. And as you can see in the first example, the push did not take into consideration adhesive related trauma. Like what should we do in this case? The answer comes from Japan. The first rejection or the first, let's say, contradiction for these facts come from the Japanese Society of the Pressure Ulcer, whom already started to develop their own tools at the beginning of 2002. They call it Design R. And they assume in this way, by using, Japan always, the Japanese planets, they have their own. They said, we will give you better tool than the push. That in the same way, so it will end by number, easy to be filled, and filled with, and bring you more informative components. والله خلينا نشوف. يلا قالوا الجمل طلع على النخله. هاي الجمل هاي النخله. خلينا نشوف. قالوا انه طبعا this is developed by the scientific committee of the Japan Pressure Ulcer, and I think if you go to the international conference, international wound care conference that's happened every 4 years, really try your efforts to attend their own lectures. Really, they're amazing in their own of thinking. And they said that we will take 6 + 1 components. We will take the depth, exudate, size, inflation, infection, granulation tissue, necrotic tissue, and in 2008-9 they add the letter P for pocket or undermining. Let's see this tool, how it looks like. This is the screenshot of the guideline of the design. And this is the updated one in 2008. And later also they updated to be design PR. So they add the pocket later 2009. And this build over revision of the records of the first version of it after revising the records of 2,598, يعني around 2,600 patients. بس هو البنفيتس for them انه Japan already they are using electronic medical records since a long time, so they have the data on computers, so this is adding value for them. طبعا بال 2012 2012 Ministry of Health في اليابان approved this to be the only wounds assessment tool, and after that it started taking international sounds and acceptance to be about it. And for the purpose, it's in the same way. So they start by the pressure ulcer, and now it's for all type wounds. And it's in the same way, we'd like to make the communication. I wanted to see if the wound getting monitored healing or not. والله الجرح بتحسن ما بتحسن. So it's in the same, let's say the same purpose for having this tool. Excuse me. The first one اللي هي D هو نفس الأحرف يعني same عندي يعني abbreviation, so design, so it start by D. It depth different than the pressure ulcer scale. لا هم قالوا go for the deepest point and categorize the wounds based on the deepest point. لأنه then go for the deepest point And if it's not debatable, unable to measure, you will write unstageable, and that's it, will end. So you will end by this category. Day 0, D0, so number will be here 0. D1 معناته في redness. D2 معناته lesion extended to derms, which is less than 1 centimeter. And the D in this case will be written as a small letter. So this is the condition. And if it's come to be lesion extended the subcutaneous tissue more than 1 centimeter, you will write the D as a capital letter and you will write it D3. إذا كان lesion extend to the muscle, so you will write D capital letter as well. And lesion extend into articular or body cavity, will write it as a D5. And if it's unstageable, you will write DU as a capital letter. That's it for the D. And make in consideration that this can be reversed. So maybe from DU to D5 to D4, each 2 weeks you should change the D. And they add a point. The only number that you will not calculate is the D. So you will leave it the D like 4 dash, then you will keep the other categories. Now we will see what are the other categories. So this is the D component. The E, which is exudate, and they define the exudate as the worst point, it's E6, which similar to the highest exudates in the pressure ulcer, but in the pressure ulcer scale of healing in the Bush, but the category was here at that time 3, here they said 6. Wallahi, if in the normal routine polyurethane foam, this dressings needs twice a day, so it will be 6. If it needs 1 time, so E3, and it depends on the amount of the wood. And the same for the size. You will take the length and the width. So you will come by A and B, but here you will write the number that you have. You will include the same number. Not wallahi converted, if it's 24, put 10, you know this. No, khalas, put it, that's it. So 5 by 5, 25, put the 25 as it. And they use the same category of 12 to 6, 6 to 12, and so on. And for the inflammation, in the same way, they use it I small letter and I capital letter, and the categories until 9. So if there is sign of inflammation will be I1, clear signs of local inflammation will be I3, and necrotic, all the necrotic put as I9, either with stomatitis fever or not. And the same for granulation. So you will end by G1, G2, G3, G4, and G5, and G6. And in this case, G0, that means granulation, but there is no keratinocytes. G1 more than 90%. And you can notice if the granulation going down, the G going up, because that means the wound is getting worse condition. And important, they added here, this is the white color. This is what when I told you about the confusion, because maybe the people who work in roads can get confused by these two types. In this case, the whitish or similar here, in this condition, worse than this condition. You know? This condition is worst. It's not healthy granulation, and mainly this is referred to biofilm, as we will come to it later. And the same for the necrotic. So we will have N1, N2, N3 until N6. N6, it's all closed and the wound is damaged. To the last point of the tunnel, and from edge to edge of the tunnel, and you will add this area. So you will put this the pocket area. You will end it by centimeter cubic. So you will take this as a space and you will add it on the wound status. So this is techniques how they can measure the pocket of the wound. Let's think about an example. I think without the example, the idea will not be clear on the design. This is sacral pressure ulcer and stageable pressure ulcer. Yalla, do it on push. You will end by 17. That's it. So this is the worst condition. Badin, so what? Look how it will come on the design D, that the depth, it will stay alone. So we will write D4 and shahta. في الاكزوديت they put 6. ايش يعني الستة هون؟ dressing change twice a day. خلص. So I will write right here 6. Size 72, they make an abbreviation for the size. At the beginning they said add it all, but then they make a different table in the last update, and the highest will be 12. So I will take number 12. Infection, this is مبين عندي inflammation, عندي dermatitis or cellulitis included in the periwound area. So I will take the highest number, it's 9. بعدين the granulation is less than 50 based on the assessment that example, so 3. There is necrotic, yes, number 3, and there is no pocket. I will calculate 6 plus 12 plus 9 plus 5 plus 3, so it will be 35. So I will write it in the design R as the following. Day D4, 35. And I will keep the following up. Here, the number that mainly will be changed to 35 will 4 in this case, but I will not make any summation for these two numbers. لو بدنا نرجع لنفس الجروح ونطبق عليه البوش, if you will apply the push in this way, so we end by 17 for a lot of weeks. يعني maybe 2 weeks, 3 weeks, 4 weeks, still 17. Oh, the wounds may be getting better, but it's out of the scope of the push. So it will give you that 17 and that's it. خلينا نشوف another example. This is also sacrum pressure ulcer, and here you can see the pocket, and they will write the design R. So they write here D3, S6, I0, granulation 1, mainly all granulation, no necrotic, pocket 24. So they collect all this number, then the number is 34, and they will write it as D334. So in this way, the same also you can apply it on this example. So we take the deepest point, and it will get you to reach it to be in a 13. So D330. We will write it in this way. This is the examples about how they try to make it easy for the people. So they said, I can give you, this is a 1 form. Now this 1 form can be in medical records, and they start to adopt an AI to help you in this performing the calculation regarding to the design. So you will end by D, which is here حاطين a bold line عشان ما تنجمع. بعدين ال E, S, I, G, and B اجمعهم مع بعض باش يطلع معك الرقم. Sum all and how much the number will be. So you will end by the design R. Another example, but it's the same, you know, another forms. The problems, you know, the originality of this form when it started in Japan. For a lot of forms in Japanese when you go to the online, but now it started to be used in the Pan-Pacific area, Philippines, Taiwan, and a lot of countries, South Korea, they adopt this guideline. And they, based on that, they now start to say when this wound should be referred to the wound care, when this wounds no need to be referred to the wound care, how much the severity, how much, I mean, a lot of studies about the design are. So this is an example about insurance parts, conditions, the parts that now start to getting more and more accepted. Now, within this category of assessment, and we are in the developing world, there are a lot of changes happening, sharing the information, and the shortage of the wound care, yani expansion of the need for the wound care, but limiting supply for the experts in, like you, in the field of the wound care. So the people start to use the telemedicine, the telehealth, the telenursing to refer it. The problem that we have it in the wound care, and wallahi, the only methodology that we can use it to transfer our information. Here I want to stress, you know, we talk about picture that someone human take it to be seen by another human, and this human will see and evaluate. So this is what I'm talking about in this. Why? Then inshallah we have different module about the softwares and the other. But here, because we're talking about the assistant. In wallahi, what if we make digital photography as way of documentation? In wallahi, instead of I will write and keep all this writing, what if I take photo for the wound and keep it on my records? Then when the patient comes later, I will check this record. There are some policy issues like the consent of the patient, the saving, the privacy, but this is all can be monitored and solved because this is only part from the hospital policies. And this can be an apart from the record for myself, so I can see the progress of the status of the wound. Another methodology or another indication say that, okay, what if Wallahi Muhammad seeing a wound and he would like Ahmed to see it and give it his back, or so instead of keep mental image with 3x3, what if I take photo for him and take it? This idea in the current world start to getting more and more acceptance and more appreciation, if of course, if we take in consideration the patient's rights and the privacy and the conditions about, which already developed later to say that instead of taking these photos and send it as it, we need a special standardization for taking this photo. So if I have wallahi iPhone, if you have Samsung, and I will send it by WhatsApp, so the quality of photo getting affected 2 or 3 times. But if I compare when you already send, for example, a photo from iPhone to iPhone by AirDrop and from iPhone to iPhone by WhatsApp, so the quality of photo can be different. So there are some legal debates about it. Can we rely or just take it as support evidence? But you cannot build a clinical care decision only on this photo. The other also, sorry, the other also challenge about the quality of the camera or phones that we are using. As we know, there are different pixels in the phones, different special cameras, and a lot of techniques about it, and a lot of debate. But this is the end ways of taking the idea. They said, okay, so if we give a special camera on the wound care clinic, but what about the floor? But what about the home health care? So there are some. And the number 3 about standardization of what are the competency required from the person who will take the photo. The ways that the photos will be taken will affect how the wounds will appear for the decision maker. So if they go to the court, if a legal issue happens, and so on. And again, I'm talking here about photo that will be taken from a human to given to another human he will see and evaluate. So this is the scope. Then later they developed using of AI and special softwares to help in doing the assessment and making decisions and so on. This is a screenshot from our textbook, and they describe about the techniques of taking the photo, the angle, the competency, and they suggest to add this as a part from the wound care competencies. If the hospital will rely, wallahi, in affiliation nurse or connection nurse in the ward will communicate with another wound care nurse in a different city, so the photo that will be sent for that wound care nurse should match specific strict criteria. So the decision, because we will rely on the decision of how he will use it. From the time of Corona, anyway, there are a lot of talking about the telemedicine and the wound care, and now there are a lot of benefits or a lot of advancements happen in the world of telemedicine. In all cases, still, we have to apply the wounds and do it in assessment. These are all what we will have today, inshallah, about the assessment of the wounds. We discussed about 3x3, and this is the most essential elements. We take 2 examples about numeric tools. And I mean, there are a lot of tools in similar way, but this is the most abundant or the most famous internationally, the Bush and the Design Arm. But of course, there are a lot of tools. And if your hospital will use any of it, so we should think about validity, reliability, and it's a good field of advancement research. And now the fields of telemedicine start to appear more in the wood care. Instead of talking, just go and see. This is the advancements come from the telemedicine and the techniques and the debates for how we take the photo in the stethoscope. Is there any question or any concern؟ في أي سؤال أو استفسار؟ الله يعافيك يا ملك.
يعطيك العافية دكتور.
الله يعافيك يا ربي. الله يعطيكم العافية. طيب سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب. في سؤال؟
يعطيك العافية.
الله يعافيك يا رب. على أحمد. في سؤال عندك أحمد؟
لا تمام بس الله يعطيك العافية.
الله يعافيك. طيب سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. نستودعكم الله الذي لا تضيع ودائعه ونراكم إن شاء الله. Thank you very much for being with us, and we see you inshallah next week from this time until our coming meeting. This is Dr. Abdul. Best regards, stay safe, and see you there inshallah. Assalamu alaikum.
Recording stopped.